I don't have anything financial to disclose. I do want to give two disclaimers. One is we're going to highlight the iovera cryoneurolysis system. There are competitor other options and versions that are out there. They're not going to be highlighted in the talk, but just so everyone's aware that this is going to be focusing on this, and there's other options out there. Number two, kind of here, I'm a little nasally and getting over a cold. I may have to pop a cough drop in, so forgive me for that, but hopefully that's not too distracting. Okay, so off we go. So cryotherapy, in general terms, is any kind of therapy that's using freezing or low temperatures to provide medical benefit. In this case, we're using it for application of cold or freezing temperatures to nerve tissue to block the pain signals that those nerves would traditionally carry, thus producing pain relief, as the brain isn't able to interpret those blocked signals as well. Similar kind of pathway to local anesthetics there. When it's applied to nerves, the cryotherapy directly applied to nerves is called cryoneurolysis. So I didn't realize this has been around forever. We were using ice back in the days of ancient Egypt and Greece, and more directed treatment in the 1800s. In late 1800s, this guy Campbell White was the first to use things like liquid nitrogen for medical treatment. And even if any of you had to or have had family members go in for little skin cancer treatments, that actually started in 1899, believe it or not, and then progressed a little bit more technologically throughout the last century. And within the last 40 years or so, we've been using it for treatment of pain. Okay, so iovera specifically, we'll talk quickly about the anatomy and the mechanism of action. So just a quick review of the nerve anatomy. This slide, I think, is one of the more important slides to kind of take home when you rationalize how the treatment works. So the nerves that we have are kind of broken down into little subsegments. A nerve is, the big nerve is encapsulated in several different types of connective tissue. The little conducting fibers are called axons, and they extend from the peripheral nervous system back to the spinal cord and up to our brain, allowing us to sense things. So there are these three layers of connective tissue. The smallest layer is called endoneurium, and that surrounds each axon. And then bundles of axons are grouped together in structures called fascicles, and they're surrounded by perineurium. And then everything is surrounded by a thicker layer of connective tissue called epineurium. And this three-layered protection system, sort of, is what really allows the cryoneurolysis to work without producing permanent nerve issues. So there are different degrees of nerve injury, we call it, based on how much destruction happens to those different layers of connective tissue. So the first degree would be like a nerve bruise, this neuropraxia, and that reduces conduction velocity. It's a very quick recovery. When it comes to how cold temperatures need to get to produce that, just even above freezing temperatures can do it, to just below freezing. We've probably been walking around outside with temperatures like this lately. Second degree is really the kind of sweet spot in terms of what we utilize to produce temporary nerve interruption in signal, but still allow the nerve to regrow and heal. That's called axonotmesis. And that, in terms of temperature, is achieved with, as you can see, temps on the right from -20 to a -100 degrees Celsius. And this kind of nerve injury results in axon degeneration with Wallerian degeneration, which is, if you remember, the point of nerve injury, the nerve and the surrounding swan shells die distally, and then they regrow in the same pattern. The important thing to remember here, though, is that all this surrounding connective tissue remains intact. And I'll kind of share my little way I kind of rationalize it and explain it to patients in a sec. Non-reversible nerve injury are these lower ones here, neurotmesis and severe neurotmesis. And that's more like your transection nerve injuries and with really, really crazy cold temperatures. That's not possible with our iovera technology. Okay, so when I describe the level of nerve injury that results from the iovera freezing treatment, the example I kind of use is, and you guys can use this with patients too, if you imagine a train going through a tunnel, like through a mountain or some kind of tunnel, the amount of destruction that happens is the train, and all the train cars get destroyed, the train tracks are destroyed, but the structure of the tunnel remains intact, which allows the workers that come to rebuild the train tracks and ultimately allow the train to move through the tracks, allows them to know exactly the pathway to rebuild the train tracks. And that happens slowly. The train tracks are rebuilt, and then the train travel is the signal that happens along that pathway. So if you look at this structure, you can kind of imagine that little train analogy. I hope that makes sense. Okay, so I just spoke about the Wallerian degeneration that happens. In the case of iovera, we target one of these, or several of these very small cutaneous nerves in the thigh and around the knee. Extremely cold zone is created along that axon, and the nerve axon and the myelin sheath both degenerate distally. So the I don't know if the mouse shows up. The top of the picture is the nerve cell body, and the bottom is the dendrites, the receptors of the nerve, and everything dies down distally along that pathway. And regeneration occurs, again, from proximal to distal in the same pattern. And ultimately, everything is restored. And that happens, it's been a proven sort of pattern of cell death and cell healing. And that's really the basis with this whole technology. So important to remember that. Okay, so this is sort of a zoomed in view of the cooling needle tips that the iovera uses to create their little freezing zone. I don't know if we have I was going to bring in a model, but basically, we'll see in a few slides. There's this handheld unit, and at the bottom there are these three little needle tips, and the reps of the company say that it creates this tic-tac-sized ice ball. So this ice ball is supposed to represent, roughly a tic-tac-sized area of freezing temperature. And ideally, we position the needle tips around the nerve, and we've got different ways to localize the nerves. And that is what ultimately produces that freezing cold temperature, targeting the nerve. So I'm going to show a little video that kind of goes into that whole process.
To understand how focused cold therapy works, we need to understand where and why it works. Let's start with a brief review. As you can see, a nerve consists of thousands of axons encased in myelin sheath within endoneurial tubes. These tubes are bundled in the perineurium, and the complete nerve fiber is encased in the epineurium. If we were to isolate a single nerve cell, we'd observe an axon conducting signals from the sensory receptors. However, once we apply focused cold therapy, conduction is interrupted, all signals stop, and Wallerian degeneration begins. It's important to note that this degeneration includes the axon and the myelin sheath, but not the endoneurium, which is unaffected by focused cold therapy. Schwann cells then activate macrophages to engulf and digest the debris, and secrete signaling factors to create a growth cone. Once the debris is cleared and the growth cone is formed, the axon begins to regenerate at a rate of 1 to 2 millimeters per day. And once the axon reconnects with the sensory receptors, conduction resumes.
Okay. So it is producing nerve death temporarily, as you just heard. It regrows at about 1 millimeter a day. The pain, as the nerve regenerates and reforms, the typical pain that the patient may be having, whether it's from knee arthritis or whether it's from recovery after a surgery, slowly returns. But hopefully we can kind of take advantage, in the case of patients that are about to have a surgery, we can take advantage of that temporary nerve injury and give them better pain relief as they recover, especially in that acute post-op phase. And we'll look at their clinical outcomes here in a bit. All right, so just to kind of summarize all the points we just learned about, mechanism of action is understood regarding the ability of the nerve to degenerate and then regenerate as long as the surrounding structure is still intact. It's been utilized for decades. That specific second-degree nerve injury that results in just Wallerian degeneration with the larger structure still intact is the key to everything. And ultimately, the newly regenerated axon returns to its original state and original function. Okay, so a little bit more about the technology piece of it. So this is a slide that gets to my point earlier, that even though this talk is going to focus a little bit more on iovera, there are other types of radiofrequency and cryoablation type technologies out there that strive to do similar things. One of the differences is that you can use iovera in this handheld unit, and that kind of shows you the size of it. At the base of that handheld unit is where those needle prong tips are. So a little bit more convenient given that, but other options are out there. Okay. Again, a little bit more highlight on the iovera specifically. So, and this also applies to cryoneurolysis in general. It's safe. It's a good option for patients that have difficulty tolerating opioids, or just going along with our general awareness about minimizing opiate use in our population. This is a nice option for general medical health. Produces a long-lasting nerve block. We can bill it, and it's FDA approved, and everything is legitimate. Lately, within the last month or two, they have moved towards more targeted needle tips. You can see on the left of the screen there's that 3 little needle tip prong attachment, and they also have longer single needle versions that are have their uses too for more localized treatment, and we can use ultrasound to help target treatment with those needle tips too. They call those the smart tips. And here's just a quick summary of how they differ. When this was first developed, they had these 3 needle prong tips as their only tip, and as we'll see in a bit, there was a treatment line that we would go across, that we would treat 4 or 5 different neighboring segments of the thigh, and I'll show you in a bit where that is exactly. And in that way, make sure that along that treatment pathway, we would hit the nerve, undoubtedly. And with these single nerve tips, using ultrasound to localize the nerve, we can visualize the whole process happening under live ultrasound. So, okay. So within that handheld unit, let me just fast forward one slide. There's the handheld unit, just to give you a sense of what this previous slide is showing. There is a nitrous oxide cartridge, that's the cooling agent, which flows, once this flow valve opens, flows down towards the needle tips and cools them for about a 1 minute long cycle. And to prevent any kind of skin or superficial subcutaneous tissue injury, the needle, at the base of the needle tips, there's a skin warmer that is designed for safety. And you can kind of see how that whole process happens in this slide. They have this gel that's supposed to mimic, human subcutaneous tissue density. And again, that sort of tic-tac sized ice ball example, you can kind of see that forming there on the bottom slide on the right. So this happens in, like I said, about roughly 1 minute cycles. The nitrous oxide cartridge is, the valve is opened, the needle tips get frosty cold and create this localized cryoneurolysis. So this is a fast-forwarded video. Same. Pardon me?
How deep is that?
The tips are about 1 centimeter. So one limitation with the three needle tip prong, or 3-prong tip, is for patients that are more obese, their nerves lie deeper. There is a layer of adipose tissue between the skin and their cutaneous nerve, and we have to, before ultrasound was included in this treatment, we'd have to kind of guess, okay, how far do we depress the tip down into the thigh? And in some patients, you really have to push down to try to get down to where you think the nerve is. With ultrasound, a lot of that's a bit more precise, but still, we're not all created the same, so that is a little variability there. All right, big annoying paragraph of, I'll just summarize saying that they have FDA approval for treatment of knee pain from osteoarthritis, and then their second indication is for improvement in post-knee replacement pain, post-op knee replacement surgical pain. And in that case, we do the iovera before their surgery and then take advantage of that slow regeneration process. And generally, as we'll see in a bit, that results in anywhere from 90 to 120 days of relief. And so they can time it, if we do it within a week or two before the surgery, to really capture that acute post-op painful phase. All right, so some more clinical stuff here. I guess starting with some basic science stuff. I'll admit I'm not really sure what this is, but I think it's a cross-section of a nerve. How zoomed in this is, it's not quite clear to me. The slide's a little vague on that, but you can see with the different stains that an untreated nerve looks largely pink, and after about that 1 week time frame, if you remember the video, this I think is showing that infiltration of all those healing cells and the macrophages and all the other inflammatory cells that flood the area to ideally heal the injured tissue. And so that's what this slide is trying to illustrate, I think. A little bit more intuitive with this one. So as you can see, the green stain is the stain for axon, the red is for myelin, and the blue are for those healing macrophages. And as the healing process continues, you've got a slow transition back to the normal green axon appearance and reduction in the blue macrophage concentration. And then they've got, I guess, these other measurements that they can show that goes along with this whole healing process, that the density of the axons in these slides is gradually improving along the lines of what we saw before with that normal nerve healing process. So safety, we want to make sure that we don't do any harm with this. And one of the bigger concerns, especially with patients that are about to have a surgery, is we definitely don't want to injure the skin or any of the soft tissue around where they're about to do surgery. and potentially impact healing of the skin or even worse, infection. And I think that's why they designed that heating plate just at the base of the needle tips to protect the skin. And it turns out that the surrounding soft tissues really haven't had any issues with this cold temperature. They even looked at hair follicles, as you can see, and sweat glands and sebaceous glands, and everything looks like it makes it through without significant problem. They looked at other structures too, blood vessels, fat tissue, very minimal issues with injury to the surrounding subcutaneous fat. Even the small arterioles around seemed to make it through without significant injury either. Okay, so they had a couple studies that they looked at. This first one is for just general knee osteoarthritis, not necessarily patients about to go on to have a knee surgery. And they looked at it with a double-blinded sham-controlled study, 2-to-1 ratio control or treatment to control group. At the bottom, that ISN refers to the infrapatellar saphenous nerve, which is just on the bottom side, just at the tibial plateau, roughly here. It kind of comes around in this manner. And they've learned somehow that not only does that nerve provide sensation to the skin, as a normal cutaneous nerve does, but actually has a large role in transmitting pain signals from the knee back to the brain. And it's amazing what these cutaneous nerves do. I had no idea myself, but so they only treated that small nerve just at the base of the knee there, and then followed them up to 120 days. And patients that had a response, they followed even further. And if anybody's familiar with Womack scores, that's pretty impressive. But these groups at regular intervals, 30, 60, 90 days, had significant benefit in pain in terms of the change of their Womack scores and specifically their pain component from baseline until day 30, 60, and 90 compared to the shams. This slide is just indicating not only is it clinically significant, but statistically significant as well. Improved pain and improved physical function based on the Womack surveys. Not quite sure if this study was born out of their original study or if this was just done simultaneously, but the second study was a retrospective study that looked at patients who were about to have knee replacement surgery. Their control group was the previous 50 patients that were about to have surgery, and then the treatment group were the first 50 patients enrolled in the iovera study. So in this case, they treated not only that infrapatellar saphenous nerve, but the other nerve that we commonly do, which is the anterior femoral cutaneous nerve, which runs along the anterior portion of the thigh. If you guys remember neuralgia paresthetica, that's the lateral femoral cutaneous nerve. Sometimes we'll include that in the protocol too, but both cutaneous thigh nerves. And it turns out nerves that are very involved in transmission of pain signaling too from the knee. So I think this is an important slide. A lot of people in this room, I think, are going to be impressed with how this might impact your jobs. First of all, significant reduction in opiate use during the first 12 weeks after surgery. And I think maybe the biggest point to hit home here is a significantly lower proportion of patients with a length of hospital stay following their surgery greater than 2 days. And that you see on the right upper chart there. Looks like something like 6. The slide's kind of confusing, but they say 6% versus 67% patients with a greater than 2-day hospital stay. And that wasn't just something that lasted the first week or two. It continued to provide benefit at the 6 and 12-week mark as well. And that last point I'm honestly kind of confused about, but we'll just skip that. So I think when we counsel our patients on what benefit it has to them, I think the most important points to bring are improvement in pain, What does that mean to them? Well, less opiate use. A lot of our patients, to the point we made before, we want to be better just as a society about limiting patients to opiates for all the negative things that they produce long term in terms of things like addiction but also for our patients that are about to have surgery, as I'm sure everyone in this room knows, some patients just really do not tolerate opiates, especially in the hospital. And so this is a really, I think, an important outcome that they were able to show. So reduction in pain, decreased opiate use, decreased hospital stay, and improvement in function. They took a look at some of their more controlled surgical settings where the hospital and the surgeon had a very kind of regimented, standardized practice in terms of pre and post, immediately post-op treatment, surgical technique, and pain management. And with this, they were able to show statistically significant benefit with, again, opiate use at 4 and 6 weeks, and significant ongoing opiate use even at the 12-week mark in comparison to the sham group. That last point, just to summarize, no change in overall adverse or readmission rates too. So getting back to the safety aspect of it. Pretty safe, doesn't increase risk of bad things happening. So this part of it sort of describes how we set the patient up and actually give them the treatment. We ask them to come in, we get pre-injection or baseline pain scores. We ask them to identify the area where their pain is. We make some marks on their knee about where their knee is generally painful, and then we have them do some step-up, step-down testing and mark those locations too. So I showed you earlier that anterior femoral cutaneous nerve. Before we utilized ultrasound, they did this with a landmark-based technique where they would draw a line from the middle of the patella up to the inguinal crease and then calculate about a third of that distance, make a mark there, and that was supposed to be that center point of that horizontal treatment line that I spoke about. And we would do, like I said, about 4 to 5 sequential treatments neighboring each other, and that they call the treatment line. And with that, we were essentially assured of treating the nerve. Similar idea with the infrapatellar branch. In this case, it was a vertical line. You can kind of see the anatomy as I showed you earlier. The administering anesthetic part, that's plus minus depending on the doctor. I think it's overkill. Some docs do it. But then that treatment tip is injected all the way. As you pointed out, sometimes we have to kind of displace adipose tissue and really try to target where we think the depth of the nerve is. And each cycle, like I said, lasts about a minute. It's really, really cold. And so sometimes it's uncomfortable for the patient, but generally by the end of it, they're tolerating it fine. May also use ultrasound guidance. We always use ultrasound guidance to localize the nerve. So the nice thing about this is that a lot of times the relief is pretty instantaneous. We should be able to see improvement, within a minute or two after we're done. So in some cases, we'll have the patient get off the table, do some step-up, step-down testing, and see how they do. If they're not feeling good, then we treat them again. Okay, last slide. Whew. Just to summarize, mechanism understood, very well understood, based on that Wallerian degeneration process and the surrounding structures remaining intact. Decades of use, millennia of use, maybe. And really all comes down to that second-degree nerve injury with Wallerian degeneration and kind of taking advantage of that specific type of nerve injury and rehealing. And that's it. Mm-hmm.
What patient comorbidities would you rule out not to be able to use this medication?
Probably skin. Yeah, if they have like an open lesion, that's a no. But otherwise, nope. Yeah, it's pretty safe and we can use it across the board.
The studies talk about pain relief. How's the rehab? How did the rehab after this tree total knee?
Pat might get into that a little bit, but yeah, the impact on post-op rehab is good as well. The thought is that with less pain, they're able to do more and get into rehab earlier and participate to their fullest capacity. Yeah. Go ahead, yeah.
Are you finding any issues with insurance reimbursement on this, either Medicare or commercial?
No, not yet. I'm sure that's, yeah, it might be a kind of thing where it's a little bit too new to provoke any insurance backlash, but yeah, we haven't run into it. We'll see if people start abusing billing and how that happens, but not yet. The way we bill at Methodist is pretty conservative anyway, so they, they're not going to be pushing the limits of billing on it, and we haven't had any issues.
How often has this been used?
How often?
How many patients do?
My first exposure to it was a few years ago, actually, when I was in the Bay Area. One of the other docs in my practice, he I think was one of the first guys that they approached, even before they started doing these big studies, to treat patients that had gone through the whole gamut of treatment for their knee pain, and they didn't have, either they were not good surgical candidates or they'd already had surgery and had ongoing pain, and this was sort of like a last resort for them. And so that was happening back in like 2012, 2013. In terms of how long we've been doing it here in Methodist, it's been like really the last 6 months or so. So pretty new for us. Those studies, I don't know if you guys saw the dates, those studies I think were like 2016, 2017.
How far along does the knee have to be degenerative before you can't use this? I mean, if you have like a knee that's bone on bone, I mean, is that even going to do anything?
Yeah.
It will do some good?
Yeah. It's not treating the actual arthritis, that'll remain the same, but it's, inhibiting the nerves from transmitting those pain signals back, and then it can result in relief. For treatment of arthritis, my main thought is that, the nerves grow back. So that is just resulting in, at this point, very temporary relief, like we saw, just 90 to 120 days on average.
Is it on any joint?
They're looking into it, but right now, just the knee.
Can you use it after surgery?
Yeah, I just treated a patient who had ongoing pain. She had a lot of nerve pain, and the thought was maybe it was from her. I'm totally blanking. From her cuff, from her tourniquet during the surgery that could have been too tight, and she had all this kind of lingering neuropathic pain along her thigh and down. And I just did her yesterday, so I don't know how she's doing, but there are patients that have had surgery that have chronic knee pain. That the surgeons are shrugging their shoulders. I don't know why you're in pain. Surgery looks fine, and it can be used for them too.
How many of the orthopedic surgeons are using this?
I think it's grown within our system. It's grown to all. Skeptics in the beginning, but they've slowly chosen a few patients and then sprinkled them in. So I think we've gotten referrals from all of them. Yeah.
So with this, with the tracing, so it's in some cases are patients using it to delay having the knee surgery,
Mm-hmm.
do more damage be done because they're delaying, or if you're bone on bone, there's really you're not going to do so much more.
Yeah. Yes. That's a simple answer. I think probably not gonna result in hastened degeneration. The good news is that we target the sensory nerves, not the motor nerves. And there are these little tiny sensory nerves that are being targeted. And so intentionally, by choosing these little nerves, we're not really putting them at risk for, I think what you might be getting at is it ultimately going to worsen their biomechanics? And maybe that will cause hastened degeneration, and because it just targets those sensory nerves and not any other, important motor nerves. Mm-mm.
Well, I guess my point was, if like psychologically you're not in pain anymore, so you're using it more than if you had been babying it before, and so would you end up with...
Right. Are you kind of masking it? Nah, maybe. I think that's a good argument. That's a really tough thing to kind of research. And that's sort of the big question with knee osteoarthritis, I think. Are you better using the heck out of your knee and otherwise staying healthy and maintaining cardiovascular health and keeping your weight down? Is that better for your knee? Or is it better to, be easygoing on your knees at the risk of maybe worsening cardiovascular health and gaining weight and that's impact on the knee? And I think it's, a tough balance, but good point. Yeah, I don't think we know that.
What percent of patients at Methodist that are going to have a total knee replacement are getting this?
I don't know. Probably pretty low, just based on... Say again?
As opposed to the medication regimen that you'd be getting pre-surgery or post-surgery, how often is it being done versus...
I don't have those numbers, unfortunately. But I think it's, at this point, still something that we've only been doing it here over the last 6 months. And, you all are asking yourselves questions about how can this work, and that was really the natural response from all of us. And especially the surgeons who don't see the patient when we give the treatment and can't really be there to sort of witness their response, and it is dramatic at times. And so then we're really just trying to dive into the scientific outcomes with these studies, and there's only 2. So,
how would that be decided? Is that just be the surgeon's preference of whether they know about it or not?
Yeah, honestly, this is such a new thing that a lot of when we first decided to start working with these guys, there were a few surgeons that within our system just tried to run their own quick little clinical study on, I think, 50 patients. And it was convincing enough to them that they wanted to continue. And that's slowly kind of expanded, and some of the other surgeons are choosing hand-picking some of their patients. Or, probably more common than that, is patient comes in through word of mouth, through advertising. I saw an ad in the paper, that kind of thing. And they say, what is this? Can I have it? And then the surgeon says yes or no.
Are those, like post-surgical, are those patients that get this pre-surgery, are they still getting the same like opioids and other pain medications after surgery, or are they receiving less of those medications?
I would point to the outcomes in the study rather than our small patient population. And we reviewed that, so my answer would be yeah. It's like the studies have shown, reduced opiate usage and pain.
What would be the percentage of patients that the nerve doesn't grow back? Is there any statistics on that?
No. Yeah. To dovetail to answer that one, my initial thought was, okay, what's the risk of permanent nerve loss? Has not been shown to happen once. And does that even temporary nerve death result in, worsened nerve pain or numbness and tingling and some of these other things that we see with different types of nerve irritation? And even though these small nerves are responsible for giving us sensation on our skin, and you'd think, well, if we kill that nerve, then we're going to be numb in that pattern. They haven't had any reports of numbness either. So go figure that one out. I can't answer that, except to think maybe there's some collaterals and stuff that we're not necessarily treating that kind of, give them some ability to maintain their normal skin sensation, but it's still tough to rationalize.
Can this treatment be done in any type of setting, like outpatient, physician office, outpatient?
Yeah, Where we do it is in the clinic, in the outpatient clinic. In terms of the timing of it, I think just to make sure that we're safe and don't have any localized skin irritation just from how cold things get, they recommend, between 1 to 3 weeks before the surgery. So it's not like we're going to do the treatment right in the pre-op area before they get wheeled back. But yeah, it's something that's done in the clinics, not so much in the surgery center or in the hospital. Go ahead.
Doing that 1 to 3 weeks out, then there's no contraindication to continuing like an adductor stem block preoperative.
No, right, yeah. For this? No. Nope. Yeah. The nice thing about targeting tiny little cutaneous nerves is that we're not getting anywhere near any big vascular structures. I had a couple pictures of what it looks like on ultrasound, and basically, most times where we target the nerve, it's right at the junction from where adipose, subcutaneous adipose tissue stops, and the quad muscles start. And to be even more, in the case of the anterior femoral cutaneous anyway, the nerve lies most often between the vastus medialis muscle and the rectus femoris muscle, just superficial to those muscles and just deep to all the adipose tissue. So there's really no big vascular things that we have to worry about from a bleeding standpoint or a vascular injury standpoint either.
How painful exactly is this? Is it like a steroid injection pain or?
No, I think it's worse than that. Because my steroid shots don't hurt. No, I'm kidding. The pattern I've noticed is that, number one, we can sometimes help with the initial poke pain. It's 3 needle tips, and that's different than just one. And then they kind of get sensitized to it, and they're sort of like, oh God, what's going to happen this time? And sometimes a second treatment, and along that pathway, their pain response is more and more heightened, just because they kind of are amped up a little bit. But we can use just simple ethyl chloride freezing spray, and that really helps with that initial poke. Not much is going to help with the actual pain that they get when that tic-tac ice ball is formed. And so that's a little bit unavoidable. But they tough it out.
Ice balls exactly go into this?
I average about 4 to 5 in the thigh and 3 to 4 along the infrasaphenous nerve just below the knee.
Is anyone else doing it besides you?
Dr. Gallant and I are doing it here. Yep. All right. Thanks, guys.